second speaker is Dr. Ahmad Alsaeed. Dr. Ahmad Alsaeed is well known for you. He's a consultant and he's the deputy chairman for the hematology and BMT department at the Princess Noura Cancer Center, National Guard Hospital. He's also associate professor at King Abdulaziz bin Saud Health Science University, and he will speak to us today about CML, the state of art in 2024. And Dr. Ahmed, the floor is yours. Please go ahead.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Riyal and the organizing committee for the invitation. So I'll talk today about updates on the CML treatment. We'll go over a frontline treatment, then subsequent treatment post-frontline, briefly about treatment discontinuation, novel treatment, and treatment of advanced stage CML. So as you know, the prognosis of patients with CML improves since the introduction of imatinib. For example, before the imatinib era, the 10 years survival of CML patients was only 10%, while now it's 90 to 95%. And this was seen in many studies in Europe and in the US. For example, in the German CML study group, the observed survival, the 10-year probability is 82, while the relative survival, I mean the death due to CML, is 92%. So that means these patients, they die from other causes other than CML. So this excellent outcome post-introduction of TKI changed the prevalence of CML. In 2000, the prevalence of CML in US was 30,000, while now is 100,000, so increased by 5 times. And the landscape of CML also is changing. So, for example, if you have 100 patient of CML and you start them on TKI, you would expect 50 patients or half of the patients to have a chance to go for attempts of TFR because of deep remission, and half of them they could continue without TKI, and half of them they go back on TKI. So around 70% of the patients will continue on TKI, and you will have 5 to 10% of the patients whom will have CML, whom will have TKI resistant or progress to advanced stage. We have currently 4 approved TKI for a frontline treatment that might be soon. Asciminib might be added to the list. So all are effective medications, and when you see a new patient and counsel him about the treatment, we have to consider what factors we will use to go for optimal TKI selection. And these factors include the treatment goals. What is the goal of the treatment? Survival, of course, for every patient, and treatment discontinuation may be for group of patients or subgroup of patients. We have also to consider the patient profile and long-term safety, as well as disease profile and cost effectiveness, or the concept of treatment value. So regarding the survival, as we mentioned, the 10 years survival is 90 to 95% with imatinib. And the question was, what is the impact of second generation TKI on the survival? And all randomized study comparing imatinib to second generation TKI did not show any improvement of survival with second generation TKI over imatinib. So in regard of survivals, imatinib and second generation TKI, they have the same survival. Now we have generic imatinib and generic TKI. So what is the impact of? They are much cheaper medications and they are affordable medications, but what is their impact on the survival? There were many studies from Europe, from US, from India, compared generic imatinibs to innovative imatinib, and it showed comparable efficacy and safety of generic imatinib to the innovative imatinib. So from survival point of view, generics are as good as imatinib. In Saudi Arabia, we have 3 generic TKIs. We have imatinib, we have dasatinib, and we have bosutinib. And this is a rough estimate about the cost of the generic TKI in Saudi Arabia. For imatinib, we have 5 generics. For dasatinib, we have 3 generics, and for bosutinib, we have 1 generic. And if you see the monthly cost for generic imatinib is ranging from 100 to 300 Saudi riyals, so it's much, much cheaper than other medications. So you have to keep this in mind. When you use a generic TKI, you have to use the same dosing, the same monitoring as per guidelines for brand TKIs. You have to do close observation for the first few months if you are moving from imatinib to generic imatinib. So you have to look carefully for efficacy and toxicity. And it's recommended that the patient continue on the same generic. Unfortunately, sometimes we see patients, they are moving from one generic to another generic because of logistic issue. Now, we mentioned that survival is excellent with TKI, but what is the needed? What is the optimal response we need to achieve this survival? And several studies showed that achievement of complete cytogenetic response at 12 months is the most important response to achieve the excellent survival in CML. So response beyond complete cytogenetic response will not have impact on survival. It might have impact on progression-free survival or event-free survival. But the most important is to achieve complete cytogenetic response to achieve this survival benefit. So if the treatment goal is survival, no TKI is recommended over others. Generic imatinib is the most cost-effective one, and you need to achieve complete cytogenetic remission. Now, what about if the treatment goal is treatment discontinuation? Is it still better to start with second-generation TKI to achieve this? So compared with imatinib, second-generation TKI generally achieve faster and a deeper remission compared to imatinib. So early response at 3 months, second generation showed higher response regarding the imatinib, and also cumulative incidence of deep molecular response with time were better with second generation. So if the aim of the patient, the goal of the treatment is to go for treatment discontinuation, you might consider to start second generation as a frontline TKI for this group of the patient. Age and toxicity is important. Older age, they have more comorbidities, so they are prone to more toxicity. All TKIs, they have off-target toxicities, and there is a distinct toxicity to each of the available TKI. So we have to consider this when we have patients with other diseases and high risk for toxicity. And we consider in patients with cardiac diseases and in patients with pancreatitis to avoid nilotinib, in patients with pleural effusion or lung diseases and patients with very high risk of bleeding to avoid dasatinib, and in patients with colitis or GI to avoid bosutinib, and patients with renal and liver disease to avoid bosutinib. So assessment of toxicity profile is also an important thing to consider when you choose the frontline TKI. What about disease profile? We know over time that CML, they have low risk, high risk, and intermediate risk, and there are many risk scoring system. And recently, the ELN, they recommend to use ELTS over SOCAL and other, because ELS developed to predict probability of dying from CML leukemia-related death over other scoring system. Also, additional chromosomal abnormalities is seen in about 10% of CML patients, and this is shown to be associated with a shorter survival and a long time to achieve complete cytogenetic response and major molecular response. So in the most recent ELN guidelines, they put presence of high-risk additional chromosomal abnormalities as a warning, and this also brings to mind that we need to do a bone marrow assessment at the initial diagnosis to look for presence of additional chromosomal abnormalities. And patients with additional chromosomal abnormalities might be considered for second-generation TKI to start with. What about the presence of additional mutations? So there are more and more data that showed some patients with some somatic mutation, they might do inferior to other patients, like ACXL1 patients. But currently, NGS is still not recommended as a routine for CML patient, but it might be considered in patients with resistant diseases. After starting frontline treatment, you have to monitor patients because adequate monitoring is important for optimizing the outcome. ELN and NCCN, they published guidelines with definition of optimal response and also treatment response milestones, so we have to follow these guidelines. Now, what is the subsequent treatment? When should we consider switching TKI after frontline treatment? So we start by this case, 62 years old man with CML chronic phase on imatinib 400 milligram. At 6 months, he has 6% BCR-ABL, completed 1 year treatment. At 12 months, it's 0.3, so it's not a major molecular response as per definition. He is tolerating treatment well, compliance is okay, there is no drug interaction. These are very important issues to look for in patients with suboptimal response. So which of the following is the most appropriate action in this patient? To do mutational analysis, to switch to second generation TKI, to switch to asciminib, or to continue imatinib. So indication to change treatment post frontline TKI are either toxicity, intolerance, or resistant to treatment. Regarding toxicity, although the available TKI are reasonably well tolerated with dose modification, but still we see tolerance in around 20% of the patients. And as we mentioned that each TKI has this distinct toxicity profile. So we need to adjust the TKI dose before we switch to another one. And for second generation TKI, you could rotate between the second generation TKI if the reason is toxicity, but not in the case of resistant. So practical consideration regarding the dose adjustment, the dasatinib lower dose now is increasingly used and recommended by many expertise. And it was shown that using of lower dose of dasatinib, 50 milligram, was as effective as 100 milligram with less side effects. Also in elderly patients, there is a trial of using even lower doses of dasatinib, 20 milligrams, and it was effective with MMR at 12 months of about 60%, and there was no progression to advanced stage with also lower pleural effusion and GI toxicity. So consider in these patients to use lower doses of dasatinib. Using nilotinib as a frontline treatment, you should keep in mind that after a longer follow-up, now we see 25% of patients on frontline nilotinib will develop cardiovascular adverse events on using 300 milligram. And the patient who use 400 milligram, the rate is higher, 33.4%. So you should keep this in mind when you consider using nilotinib as frontline. For bosutinib, escalation dose is recommended, especially in elderly patients, to minimize the toxicity. So dose adjustment is important in these patients, but there are some toxicities, what we call it prohibitive toxicity. If it develops, you have to change the TKI, like pulmonary hypertension and recurrent pleural effusion for dasatinib, pancreatitis for nilotinib, and arterial occlusive disease for nilotinib, and enterocolitis for bosutinib. Now we come to the resistant to treatment. So 10% of the patients, they have resistant to treatment, and the definition is either to have loss or no complete cytogenetic response, which equivalent to 1% or more of BCR-ABL, or transformation to advanced stage CML. So the question is when to change. So doing BCR-ABL at 3 months, many studies showed that if you do not achieve less than 10%, this is maybe associated with inferior outcome, but do we need to change at 3 months? The only maybe indication to change if there is no hematological response, or if the BCR-ABL is still significantly higher than 10%, for example, 50%. At 6 months, you change imatinib to second generation of the BCR-ABL is more than 10 months. But if the patient started on second generation TKI, you might need no change except if there is a guiding mutations. And at 12 months, our patient, he did not achieve major molecular response, but it was less than 1%. So you might need not to change the medications if the aim is survival. But if the aim is to go for treatment discontinuation, you can consider to change the treatment. Now, for So for older patients, you might not need to change if the cytogenetic response is partial cytogenetic response, because achievement of partial cytogenetic response is associated with good outcome. So now for patients whom you need to do further subsequent treatment, the question is ponatinib versus asciminib. There is no direct comparison between them, but it seems that ponatinib is more potent, but you have to consider starting with lower doses of ponatinib to minimize the toxicity. And just 2 minutes about treatment discontinuation. So this is many studies showed that this is can be safely, TKI can be safely discontinued in patients, and ELN mentioned criteria for the patient. The most important criteria is to have a sustained deep molecular response, because if you have MR4 less than 5 years, the chance of TFR at 2 years is 67, while the chance at if you have MR4 and beyond more than 5 years, the chance of TFR is very high, 91%. So also you have to monitor the patients closely after TFR, and when to restart treatment. If the patient loses the major molecular response, then you have to restart treatment. 95% they will respond the same TKI, and the progression to accelerated or advanced stage is very rare. And one clinical issue that there is characteristic polymyalgia-like syndrome when you discontinue the TKI, and this can be treated conservatively. There are some strategies to improve the TFR. The most important one is the combination treatment. So interferon showed some superiority, but there was no significant difference. Ongoing trial is using pembrolizumab plus TKI or ruxolitinib plus TKI to improve the deep remission. Example is the adding ruxolitinib to nilotinib, and ruxolitinib in these patients associated with significant increased rate of MR4. And this is just one paper from our center regarding the treatment discontinuation. Second trial is not recommended routinely. There are some ongoing studies to improve give a patient a chance for second TFR by adding ruxolitinib or asciminib to imatinib. Novel TKI, Dr. Naim, he talked about it, only about Oliver imatinib. This is a oral third generation TKI. It's effective in patients with T315I and in none, and so it's approved in China, and there is ongoing studies in US for this medication. And there are investigating combination dasatinib with venetoclax. Unfortunately, it showed no significant benefit over dasatinib, but there is decitabine and dasatinib is ongoing trial with oral decitabine and dasatinib in chronic phase CML patients. So I think I will skip the advanced stage CML. Thank you.
Thank you very much.